Okay, so I think we can start with the introduction. Welcome everyone. Dr. Daniel Butler is here with us today. He's a board-certified dermatologist currently practicing in Tucson, Arizona, where he's an associate professor and assistant dean of student affairs at the University of Arizona College of Medicine. He's also director of the Inflammatory and Aging Skin Research Program and co-founder of the Geriatric Dermatology Expert Resource Group. He's a social media editor at the JAD, associate editor at the International Journal of Women's Dermatology, and has received numerous accolades during his career. And we are very excited to have him speak to us about aging and the skin. So without further ado, over to you, Dr. Butler.
Well, thank you for that wonderful introduction. It's really exciting to get to speak to everybody and to be invited with this group. I've watched a lot of these lectures, and you have some really wonderful ideas and creative people on here, and I'm just happy to be included. So thanks so much. And I think we have an exciting topic, or at least one that I know 100% pertains to everybody, and this is aging and dermatology. And we're going to use this as the lens to take a look at how we change with time. And of course, this is going to have a patient piece to it, but I'm also going to put in a little bit about us as dermatologists or dermatologists in training, because there's a lot to how we change over time, and age is the factor there. And so one of the pieces I'm going to also touch base on, I know it seems a little bit random, but I promise to tie it all together, is burnout and how that plays a role for us, and how perhaps, the care of a unique population or even an aging population can help us with that. I do have my Twitter handle at the bottom there. I do think it's great to have a social media presence. So please tag me, chat with me if there's anything I can answer on here. It's at Daniel Butler, MD. So without further ado, let's get into aging and dermatology. Here are my disclosures. All of these are looking at and working with companies that are focused on treating patients with conditions that are associated with aging. So I'm actually proud that we're having more and more people who are looking at this. So I want to start with two patients, and these are two patients where there's no right answers. There's no quiz here. This is all about what these patients represent. So the first patient is a 78-year-old. He's been itching for 2 years. He's active and independent with his activities of daily living. These are his ADLs. And he has subtle erythematous papules on photos, but when he's in the room with you, there's unremarkable changes on exam. His labs are all relatively normal, except a slightly elevated creatinine, which has been there for years. And his biopsy showed an urticarial hypersensitivity reaction. And you'll take a look that he has these sort of nondescript erythematous papules and plaques. They're not truly urticaria. They look a little bit more urticarial, but this is a really common patient that we see. And the challenge is we don't really know what to call this patient. So keeping that patient in mind, let's move on to the other one that's a challenge as well. So patient number 2 is a 98-year-old with a history of advanced dementia. This patient has been itching for 14 months, and the itching keeps the partner, who's the caretaker, awake at night, as well as the patient. On physical exam, all you're seeing is excoriations. Again, labs are normal, and the biopsy just shows excoriations. Sometimes that reads as lichen simplex chronicus without surrounding inflammation. And here's just a picture of excoriations. So these two patients are reflective of something that's really hard to capture. These are two patients that I think our specialty in dermatology has that with blame. I say that opportunistically. I think these are two patients where we really don't know what to call them. We really don't know how to treat them. And that limits our ability to ultimately study them. And, this is a challenge for anything that's looking at or with the factor of age, because age is something that's going to change everything that we think of with a schematic, with a disease schematic, with a presentation schematic, and it's going to splay apart all the different ways that we like to put things into buckets really nicely. And so I put age on this slide alone to let us all sort of sit with it and let it sink in, because it's a word that we have complex emotions about. So a lot of people think of age as something to be avoided. That's certainly a piece of it. I would argue that it's not age we're trying to avoid, it's some of the signs or symptoms of aging. There's a piece of age, though, that we all desire. I like to always tell people that aging is also the goal. I'm certainly not someone who wants a lot of the stuff that comes with aging, but I also have seen people age, and we want the perspective and the wisdom and the time and experiences with people that we love and enjoy. That's also a gift of age. And so this is certainly something that we all have to toggle with in our day-to-day lives. And then as dermatologists, we have to deal with it with our patient populations. And I think it's best to approach it by just unveiling how challenging this concept is. So I think if we look at age with regard to dermatology specifically, and we're lifting up that hood, I think one thing that we have to acknowledge is what's the real focus of age in dermatology? And unfortunately, or fortunately, depending on where you lie, it's really with anti-aging. So anti-aging is where a lot of the eyes are when it comes to dermatology and aging. So if you look at this chart here, 75 plus $billion go into the anti-aging market. And this is only growing. This is massive. So the VA budget, just so everyone knows, this is our biggest healthcare system in the country. The VA budget is about 110 billion. So obviously it's not there, but this is a massive amount of money looking at the anti-aging market. And there is a truth that this is a huge piece of what we are. And while it's not everything, I think there's a truth that this is a piece of us, and we have to acknowledge that this is a focus of aging. But there's also another piece to this story, and that piece is who we're seeing in clinic. That starts with understanding what our population is doing, and there's an easy answer to that, and that is that our population is getting older. So here you see a demographic split of how our country is aging. So this is for the United States. And the easy trend to note here is that the aging population is increasing. So you can see that our population will be probably over 20-25% by the end of this decade. And this is a phenomenon we're actually seeing internationally. So places like Japan are seeing percentages of patients over 65 in the 40s. So we're looking at almost half the population there being over the age of 65. So this is an international trend, and it's only increasing. So whether you think aging is just an element of anti-aging or not, it's coming your way. Now let's look at this from the perspective of the dermatologist, or certainly the dermatologist in the United States. So here's a makeup of all the patients that we see in dermatology clinics. And if you look at those bar graphs above 65, you'll see that about 40% of all patients seen by dermatologists are over the age of 65. Now, if you take out the pediatric patients, which make up about another 10%, you're looking at clear over 50% of the patients that we see in dermatology clinics being over the age of 65. So yes, there is a certain piece of aging in dermatology that is anti-aging, but there is a total argument to be made that there's a huge piece here where dermatology is actually 50% of people over the age of 65 and aging. So there's so much of that complexity that we talked about just in our specialty, and we can be a microcosm of the complexity of how we look at age. I want to make one side claim here, which is that 65 is a number that we delineate as older adult versus younger adult. Now, I would argue, and I want to be clear about this, that 65 is not old. That's just the number that they often use to communicate age. But I would argue that aging or being old is more of a factor of functional ability rather than an age number. So I always like to put that disclaimer out there. So now I go back to how dermatology and aging connect. But this is the truth here. We are seeing these patients in our clinics, and there's a lot of complexity in our field. So I think at this point, we have to ask ourselves, going back to those first two patients, hey, so why are we neglecting this huge population? It can't be just that there's an anti-aging influence. What is going on here? So despite the fact that there is, over $70 billion going into anti-aging, there's nowhere near that amount or any amount whatsoever going into specific aging research in dermatology. And that means that these patients are always going to be difficult for our field. So I like to always talk about why that is. So number one is nomenclature. So as we see the factor of aging influence our diseases, we see that there's differences in what we call our diseases because they present differently. So the best example of this is one of our flagship diseases, itching. We're really the chiefs when it comes to looking at itch. And itch is absolutely a disease of age. It absolutely increases across genders and across populations as it is with aging and with years. But if you look at the nomenclature for one of our most chief diseases, you'll see that it's all over the place. Now, this is not out of any type of ignorance or stupidity. These are earnest attempts of defining this population. But the truth is that we've splayed and scattered the nomenclature so significantly that it's been hard for literally hundreds of years to study this condition. And so that's one thing, is that aging poses an influence on how we define diseases, and that makes it so our nomenclature can't be collaborative, and it cannot be inclusive, and that limits our ability to ultimately study and better understand these patients. This is just an abstract that we published a couple years ago, and that's the abstract number, but it always helps me put this point across that there's 25,578 inconsistencies in the literature for pruritic eruptions in older adults. So let's look at number two. So now we have nomenclature. Number two is exclusionary regulatory structure. So limited treatment data. So what do I mean by that? When you look at how our flagship diseases are studied and developed for medications, you'll see that there are actually exclusionary practices of older adults in clinical trials. So we actually have infrastructural ways that we exclude aging in how we study disease. So these patients are actually systematically being excluded from our flagship diseases. This is certainly not a dermatology exclusive problem. This is across all clinical trials, but this is something that we see, and we have to take a look at why our systems are excluding our older adults in order to better understand why they're challenging us. Because we often are posed with questions of, hey, what's the best treatment for this in this older adult patient? And frankly, we don't have the answers like we do for our younger cohorts. So the next one is the omission of geriatric care principles. So my wife is a geriatrician, so this one is very important in my household. And why I think this is so important, and I think this is so important really for all specialties in medicine and across the field of medicine, is that we are getting hyper specialized. We are so good at dermoscopy, or we're so good at minute changes in immunosuppression or at surgical techniques, that often we forget that step back approach and what really matters to people. And those are the geriatric care principles. Sometimes my wife calls them just the common sense principles. And it goes back to that famous Jurassic Park quote, which I always butcher, but it's something along the lines of, we could do it. There are things that we can do as specialists, but we always have to ask the question, should we be doing it? And that's where the geriatric care principles come in. So these are things that are really not included in our educational systems and educational models, but they're things that are really common sense that we need to be including in how we practice. And these are the 4 M's that I always like to teach people about that are prevalent in the geriatric care world. So these are what matters most. These are medications. These are mentations and mobility. So those are the 4 M's. And these are things that we don't always include in our treatment algorithms and the ways that we approach patients. Certainly, you may use it from time to time by yourself. Certainly, you may see it in a really good provider, someone who's seeing patients and just intrinsically uses these. But I would argue that we certainly spend more time doing tons and tons of other things than spend even a minute period of time using these principles. And because we don't have these, it makes it hard to wade back into them once we're finally in practice. And then the last one that I think is really important here, and it sort of is embedded in all the other concepts here, is variable physical exams in older adults. Like I mentioned, aging influences all the diseases that we see. And our superpower as dermatologists is our physical exam, our ability to see a rash, see a morphology, describe it, come up with a differential. But when aging influences that ability, and sometimes influences it in a way that makes us confused, this is how we look. We look absolutely lost. And, I think one of the best examples of the variable clinic presentation is bullous pemphigoid. So bullous pemphigoid is almost exclusively a disease of older adults. And yet our specialty has had a really hard time defining the variety of presentations within bullous pemphigoid just because they present with different skin findings. So you have a patient who presents with bullous pemphigoid who has serologic positivity, who's really itchy and has a little bit of eczematous rash versus the person who has full-blown blisters. Are those different diseases? Even if they respond to the exact same things, I won't have that debate here, but it's certainly been a challenge for our specialty to really be inclusive of all these patients. And that's purely because of the morphologic differences. And there's total reason behind that. This is not me being critical. There's reason behind that. We were developed by our superpower to be able to morphologically find and diagnose diseases. And when that's taken away, it really changes how our field approaches things. So now that we know why these patients were so challenging, I always like to make this a little bit personal to help everybody understand why I'm so into this patient population. And part of this is personal from my family. So these are my 4 grandparents. I was lucky to have all 4 into medical school. I now still have one, Joni right there in the middle on the left with the big smile. And they were the ones who showed me that complexity of aging, that aging is not just something to be avoided, but it's something to be honored. It's something to seek. And it's something that we all hope to do in a really special way. And one of the ways that we do that in our own special way is with the help of doctors and the help of providers and caregivers. And so it really is our responsibility, or at least I feel that responsibility, to be part of someone's aging journey and make it as special as possible. And certainly because we're seeing about 50% of people who are over the age of 65, we are absolutely a part of that journey. And I feel like dermatology plays a unique role there. And so, to my personal journey is I became interested in, I was always interested in older adults, but when I got into dermatology and I was focused on dermatology, I was really interested in itching, still am. And I found that when itching would come up with older adults, we had this sort of stock answer. And it's a little bit embedded in this chart, but I'll tell you why I became obsessed with this chart later in my career. And that's because I felt like almost every chart that I saw with itching in older adults had 2 really overly simplified sides. So one was the itch with rash, and that is what we're best at, right? That's changes that we can morphologically find. That's, the patient who has a subtle vesicle and we can diagnose them with bullous pemphigoid very early. We're really good at that side of the equation. And then by the end of my first year of residency, I could do the other side, which is itch no rash, right? That's something that we always are talking with our trainees about. So what is your workup for itch no rash? And, you have your 5 or 6 or whatever lab tests that you're going to order for this differential. You got that down by the end of your intern year or the end of your first year of derm residency. And while I saw those at play, what I was actually seeing in clinic was a different population, a population that didn't have definable skin disease, and a population that when you sent those labs, there was nothing in those labs. And so my fascination with this specific chart came up because it was the first one to acknowledge something that I think all the other charts neglected. And they said it beautifully here. It's very simple. This is from Gil Josipovich and his group. But this was a dermatologic cause that was not recognizable. Excuse me. And while there's certainly more to this story, I absolutely think that this is, excuse me. Sorry, my my son my my son has given us 2 great weeks of hand, foot, mouth, and pink eye back to back. So I apologize that this is happening, but this is what happens with a toddler at home. One more second. All right, we're back. So this is where the non-recognizable causes of dermatologic disease, I think, really highlight a truth about where we are with this population. And this isn't just for itch. This is for all older adults that, hey, we can acknowledge that we're not perfect at treating this population. So let's get to work at trying to figure out what's making it not recognizable and what are ways that we can start to recognize this population. And anytime you're starting to ask questions like that, I always like to go back to the history and look at, is this just like a new problem that we started to have recently? Or is this something that has been around for a while now? And if you look, this has actually been thousands of years. So Paul of Aegea actually described itch in older adults and described it as the itch that comes about that cannot be cured, but can be alleviated by a number of procedures and remedies, including phlebotomy, baths, and salves. Sorry, everybody. Thanks for hanging with me. So where do we go from here? How do we start to piece this together with something that makes sense, that can give us some answers as to how do we start to take this neglected population, chip away, and start to understand them? And I always think that this starts from a basic science standpoint. So the complexity of how we view aging, with the anti-aging element, and yet the ubiquity of our older population in clinic, it does have a combined center, and that is in the basic sciences. And so if you start to look at aging there, you can start to get to answers to all of these sides. And this is what I think is so exciting, because this is really brand new in the dermatology space. So let's break it into the 3 areas that I love to watch it. So one is in the immune system. So the first thing I like to talk about as we unveil sort of the nature of how we're going to ultimately understand this population better is this concept of immunosenescence. So certainly immunology is a hot ticket item right now. And I will say that I think when I was taught about immunosenescence in medical school, I was taught that immunosenescence is an age-related decline of the immune system. And I think that's one thing that if you leave this talk today with anything, is that that's not true. Immunosenescence is a decline in some elements of the immune system, but for the most part, we're actually seeing a growth or an increase in activity of the immune system. It's just in dysregulation. We're seeing a dysregulated element of the immune system. So think of it as a less targeted approach and a more splayed approach of the immune system, as opposed to a decline in the immune system. And this also relates to a concept called inflammaging, which is an age-related increase in pro-inflammatory markers in the blood and tissue that are strong risk factors for multiple diseases. So this is related to many aged conditions, and I argue that skin should be right up there with many of these conditions. So you'll see on the bottom of that chart, cardiovascular disease, type 2 diabetes, CKD, cancers, depression, dementia, osteoporosis, sarcopenia, anemia. These are all things, these are all end causes of this inflammatory cycle that we're seeing in the immune system of older adults. And I would argue that the skin is the most obvious of all of these. We are seeing changes on the skin, whether that's purpura or itch or actinic keratosis or frank non-melanoma skin cancers. These are all manifestations of these conditions coming to play. And so long story short is that there is a lot to the skin that can give us the mysteries of these aging processes. And it doesn't just stop with the immune system. If you look at the cutaneous nerves as well, you'll see a lot of the similar stuff. So in this study, you can see that there's actually a decrease in the total number of nerves, in the density of nerves of our aging skin. But just like immunosenescence, you're also seeing a dysregulation of the nerves. And that's why you're going to also see a lot of these sensation changes in older adults, whether that's just itching or even frank delusions of parasitosis. These are almost exclusively diseases of older adults when you're taking out other modifiable risk factors. And then the last one, when you're looking at basic science, and again, I know I'm oversimplifying, each one of these slides is its own career in the basic science world, is you're seeing changes in our ways of actually, guarding our skin from a barrier standpoint. And all of those ultimately then cycle back and play a role with the nerves and the immune system. So these are all communicating systems that play a role in this aging process. And whether you're looking at it from a pathologic standpoint or looking at it from an anti-aging standpoint, this is the true bedrock of aging and the skin. And just like what I was saying about the barrier or with the other systems, it's ultimately with the immune and nervous systems. What we're really seeing is a lack of responsiveness, the appropriate responsiveness from the barrier, just like we're seeing with nerves and the immune system. And so this is just an example of how we can ultimately start to take some of these bedrock pieces of aging in the skin and apply them to some of our flagship diseases. So I personally think, and this is my bias, that itch is a great way of discovering the mysteries of aging. We're seeing it play out in front of us. But really what you can do is take these bedrock pieces where we know what's actually happening from a basic science standpoint, and then start to apply them to a disease schematic that's not just singular. It's not that every person who's itchy has an immunologic problem or a cutaneous problem or a neuropathic problem. What happens with aging is they all combine together. And you see this mixing and matching. And that's why one symptom can have multiple different things contributing to it, and why it's so hard for us to ultimately be able to profile, diagnose, put them in a bucket like we do with our other diseases. So this is a great example of how we're ultimately taking some of these challenges and being able to combine them into a schematic that's actually meaningful. So we're working on a paper with a couple of journals right now to actually put this into a schematic and send this out there to dermatologists and primary care who see these itchy older adult patients. And once we have this schematic changed for a flagship disease, we're just using itch here, but this could be for any of our diseases, then that can dictate how we use this to approach patients. So if we're looking at a patient for itch with neuropathic itch and primary cutaneous issues, we're going to use our ability in working someone up to discover which of those pieces of the Venn diagram the patient is having pathology, or which two or all three of them. And then once we have a better idea of where the pathology is, we can use that from a treatment standpoint. We can target the immune side, we can target the neuropathic side, we can do it simultaneously with two medications or do it with one medication. So I like to use these up here. Again, this is not a comprehensive treatment chart, but you can see one of my favorite treatments, because one of the things I think is most common for itch in older adults is a combined immune and neuro itch, is to start with triamcinolone and Sarna applied together to the entire area where the patient is itchy. And then, depending on how they respond to that, you can escalate either on the immune side or on the neuro side. And that's how we start to treat these patients, as opposed to thinking of them all in one narrow walk and just hoping that topical steroids or dupilumab or gabapentin can help them. Often we have to think of this as a combined process, because aging is not a singular process. There's multiple influences, and that's what's made its characterization so hard in our specialty. But it's also what gives our specialty such a great opportunity to ultimately figure out what's going on with these patients. So the ultimate goal here, and I'll talk a little bit more about these, is to endotype these patients and figure out exactly within our flagship diseases, what are the endotypes that aging patients actually have. So for example, for an itchy older adult patients, some respond to purely neuropathic treatments. Some respond to purely immunologic treatments. So we have actually coined a term called the immunologic eruption of aging, which is a patient who's had chronic pruritus, who's had a completely negative workup, and yet they respond to some sort of immunosuppressive treatment. Sometimes that's wet wraps, sometimes that's phototherapy, sometimes that's biologics, but this is that pattern of patient. And so if you think back to those initial patients, those patients that we've struggled to ultimately define, this is how we start to chip away at it. This is how we start to look at aging and dermatology and say, hey, we know that this is a complex risk factor. We know that this is a complex influence on our classic diseases and our schematics of how we define diseases. But there is a path forward as we look at basic science, common practices, and then ultimately how these patients present. So it's an exciting time for anybody who's looking at aging, because in dermatology, the space is wide open for us to run. And this is one of my favorite quotes. If you don't know Brene Brown, she's a super, super famous social psychologist, and she has all these wonderful quotes that everybody adores, including me. And I love this quote. It's, "I'm not here to be right, I'm here to get it right." And I think this is such an important one that we should all have in our brains as doctors. And it's really hard to get there because we've sort of been taught for our entire careers that there always is a right answer. And there's one thing that's causing this. And if we figure it out, then get them on the right treatment, and we'll solve the problem. And I don't think that that's true. And I think aging patients, particularly in their complexity, allows us to sink into this mindset. And that can be actually really helpful and liberating as we approach patient care. And then that picture on the other side is so perfect for us as dermatologists, right? We spend so much time looking into our dermatoscopes, trying to find the answers in there. And sometimes the truth is step back. The truth that can only be seen when you step back. And so I love that there's sort of two angles to everything that we're seeing, and not disparaging anybody from using their dermatoscope, but always take that step back approach. It's so important with older adults. And so this is where I'm going to get to chat a little bit about something different. And that Brene Brown quote really hits home because, again, with older adults, we've sort of been seeking the one answer. And I think when someone comes in with an unanswerable question and we can't answer it, it's really, really hard, particularly when there's another patient waiting who, you're 10 minutes late, and, now the messages are stacking up in your inbox, and, you're late on 2 projects that you want to do, and you get an email that you have to, you're going to have to see 16 patients instead of 14 next year. So this is exactly what's happening in dermatology right now. We're feeling this pressure from multiple sides about burnout. And I think there's a lot of pieces to that. And obviously, this is not the place where I'm going to dive into every piece of burnout in dermatology or across medicine, but it's a major problem. I mean, 50% is about the average for all specialties. And that is so depressing as someone in medical education, as a doctor, as a dermatologist, to think of 1 out of 2 dermatologists is feeling burnout is really a hard thing to swallow. And I think it's something that we need to talk about, just like, how we don't have perfect answers for all of our conditions in older adults. I think the way that we get to solving problems is, again, unveiling them and talking about them. So while this is a major problem, I do think that there are factors that we can control. To the same end, or the opposite end, there are factors that we cannot control. And this is one that I think is really challenging. This is the loop of despair that I always talk about. So this is you as a dermatologist seeing a patient, putting something in the EHR. That EHR prescription goes to a specialty pharmacy, then it goes into the abyss of the insurance company for approval. Somewhere in there, it touches base with the pharmacy benefits manager, who, that's a whole other discussion we can have. And then maybe a fax gets back to your office and hopefully gets back to you. This whole thing is a horrible loop of depression that we all are in all the time. And while this is the new reality, we have to find ways to operate and find joy within this really, really challenging loop. And, sometimes that is increasing staffing to help with this loop in whatever phase it's in. But a lot of the times it's also finding joy in other ways, and also taking pressure off of ourselves to be this perfect diagnostician constantly, and also lean into some of the challenges that we all face and discuss them together with our entire team. So I always think of, when I'm stuck in that loop, I always think of my grandparents, because they're the ones who instilled why I want to be here within me. And that's really the piece of aging that I think is so important, is aging patients, similar to your pediatric patients, and certainly not untrue for adult patients, normal adult patients, is they should be the people that make you reflect the most about why you're doing something and why you're making that decision, and making sure that you are honest as you approach those patients with, hey, this may not be the thing that works for you, but hey, let's give it a try. And I think if you can stratify and walk both those lines as a specialist and just someone who's really empathetic and cares about the existence of this person in front of you, I think that's possibly one of our best anecdotes against burnout. It's certainly not a 30-minute yoga session that's forced by a department or a hospital, and it's definitely not wellness modules. So with that vein in mind, I'm not just trying to be preachy. I also want to give you some of these therapeutic pearls for older adults and to help avoid burnout. So this is sort of the coming of the conversation here, which is ultimately that, I want to give you something to take back to your practice that is effective for aging and dermatology, and hopefully can be a little bit, just a tiny bit, restorative of that joy of practice, as you remember that there is something beyond that loop of despair. So number one, therapeutic pearl is patience. This is one of the hardest things for me. I really struggle with this, particularly when I'm running late and my empathy is low by the end of the day. But when you're seeing somebody with a complex presentation, and I mean that from either a disease standpoint or a social standpoint, which is often the case in older adults, be patient. Take pressure off that initial visit, and just consider close follow-ups if that needs to happen. And then reconsider everything at each visit, because you may have some new data, you may have a new data point, you may have a new caregiver. I think of this particularly with itch patients who come in. They usually come with a stack of papers. They have a whole story as to what's happened. And sometimes you just don't have the ability to spend 30 or 45 minutes as is deserved for that patient. So sometimes after 15 minutes, you say, hey, I'm going to give you this triamcinolone and Sarna. I'm not 100% what's going on. I want to read about your chart. Let's have you come back in a month, and we'll schedule you at the end of clinic so we can have a little bit more time to talk. And you'll reconsider everything at that visit. So remember to be patient with yourself. There's a lot of pressure for dermatologists to walk in a room and know the answer immediately. And often, particularly for older adults, that's just not the case. Number two, you heard me talk or crow about the therapeutic or the 4Ms, but it's so important to remember these. So this is exactly what I do when I'm remembering my grandparents. It's always remembering how I would want my grandparents treated in a doctor's office. And I think it's so important to treat everybody like this, but particularly older adults. So just remember the 4Ms: what matters most, mobility, mentation, and medications. All of those are so important to keep that step back approach. So when you're getting lost in that really fine minutia, whether that's labs or dermoscopy or a biopsy, just take a step back and remember these 4 M's are really the crux of your treatment for any patient. And that can be really liberating because it takes you away from A, getting the right answer, and rather it switches you to B, which is getting the right answer for that patient. Number 3 is communicate uncertainty. This is what I loved about Dr. Yosipovic's chart, which was not recognizable dermatologic causes. It's okay to not know exactly what's going on with a patient or the prognosis for a patient. For older adults, this often comes up for non-melanoma skin cancers and the question of what's going to happen if we do or don't treat these patients. And it's totally fine to say, I'm not sure of this. This is what I do know, though. And communicating that to the patient is really helpful for the patient. And it's honestly really liberating for us as providers because it can take that pressure off having to know all the answers and exactly what's going to happen. So if you just say to the patient, hey, I'm not exactly sure what the perfect answer is here. We'll talk a little bit more about this on the next one. You can really help yourself. And I think this is really food to avoid burnout as well. Really, the next piece of that pearl is therapeutic pearl 4, which is shared decisions. We've all heard of this concept of shared decision making, and it's underutilized in dermatology, unquestionably. I use 2 examples on this slide. So one is for the escalation of treatment for any chronic inflammatory skin condition, and the other is for a procedure or no procedure. I think of this, this is more intrinsic in pediatric dermatology where, you're not doing a biopsy unless you absolutely have to. And I think we need a little bit more of that in dermatology, or at least a little bit more of the analytic approach to biopsies and procedures in older adults. So what I tell people is try to avoid what I call the conveyor belt dermatology approach, which is see a disease, treat a disease without a discussion. So basically, you see a basal cell, you cut the basal cell off, they're on the conveyor belt, they're headed for Mohs. I am not anti-Mohs by any means, but you have to have a conversation about if that's the right approach for somebody. So I have people who are really limited in their functional ability, but when I tell them about their options for a small basal cell on their cheek, and they hear about what Mohs is and they choose it, I think that's perfectly the approach for them. Conversely, I'll have a 65-year-old patient who's very functional who wants to try Aldera for that same basal cell. And as long as they know that there's a lower chance of clearance of that basal cell and he or she are going to follow up with me, that's the right treatment for them. That conversation, though, needs to happen. And that's the most important thing. And I think that starts with that sort of humble piece to this of acknowledging what you don't know. And I always start off conversations about what the right treatment is or the perfect treatment is by saying, there's no right answer here, but here are the options. What do you think? And sometimes they'll come back to me with a harsh, well, you're the doctor, why don't you tell me? And then I will give them exactly the direction that I think they want to go. But sometimes you'll get really unique perspective from that. And that's where those shared decisions come in. And I think that's such an underutilized skill. When I'm teaching, I always talk about what you have in your toolbox when you're really challenged. And so shared decision making is probably the most effective thing that we have in our toolbox that we don't use. So think of it for that patient who comes in, who's 85, who has 6 skin cancers, you're 30 minutes behind. Sometimes it's fine to just say, hey, we're going to take a couple of these off. We're not going to send you to Mohs depending on what they are. We're going to have you back for a discussion of what we're going to do with these. And that's completely appropriate to be patient, share decisions, and acknowledge to the patient there's no perfect answer. And then the last one that we're working on from a more formalized standpoint is reframing outcome measures. So part of this is getting us away from our complete reliance on physical exam. There's a lot of ways that we can measure diseases that are not just how much scale or redness or the size of a lesion may influence the severity of that disease. And so I think for older adults, and really for everybody, but specifically for older adults, we need to start changing how we are actually measuring the success or failure of treatment of a disease, or how impairing that disease is. So I always use these proxies. So one is sleep, another is activity level, and the last is caregiver burden. So those are all three questions that I ask when I'm treating older adults for either skin cancers or inflammatory conditions. And that helps dictate to me how much more aggressive I have to be or how much less aggressive I have to be. So here's an example. If somebody is comes in and they say, I'm really itchy, and I say, well, are you sleeping at night? And they say, I sleep like a baby. I don't sleep at all. Or I have no issue sleeping. Maybe I'm going to be less aggressive as far as how I'm going to treat them. But conversely, if I have somebody coming in with a non-melanoma skin cancer that may be in a lower risk area, say it's on the upper back, but it's really bleeding and that's affecting the caregiver because the caregiver is the person who has to change it or has to be out with them in public and they keep getting this blood stain on their shirt, that influences how aggressive I want to be at treating it as well. And it's not just me looking at the lesion, seeing, what could be a superficial basal cell or an uncomplicated nodular basal cell. It's really asking the patient's experience with what we know, because we are often way too reliant on what we see on the path and not what the patient's experience is. So if you could start to include these in your disease schematics and how you're ultimately influenced by them, I think that also has a way of addressing this aging conundrum, but also helping you be your own independent provider, practitioner. And that is really helpful for avoiding our problem with burnout. So let's talk a little bit about the future before we go into any questions. So the future hits on a lot of things that we've already talked about. So basic science. I told you that there's over $70 billion in anti-aging. Well, aging as it relates to our flagship diseases in dermatology, there is so many ways that we can look at basic science. In fact, there's really not many people looking at the basic science of aging and skin diseases. So there is so much growth there. If anyone's interested in it, I'm so excited to partner with you. So let me know. The next one is disease endotypes. We have diseases like itch that I've beaten with a drum today, but others like pyoderma gangrenosum, granuloma annulare, squamous cell carcinomas on the legs. All of these have unique presentations in older adults, which all share unique prognoses and unique workup elements to them. And so there is a whole world within those specific diseases and countless more that we could start to endotype older adult populations of those flagship diseases and not just include them in the mix of everyone. We can actually find nuances of those diseases within them. Some people say, well, it may not be the same disease then. And my answer to that is, we can be splitters when we need to be, and we can also be lumpers when we need to be. This goes to the next point, which is we live in a world where when we split, we sometimes limit our patient's ability to get access to treatment. So when someone asks me, are you a splitter or a lumper? I'll say I'm whatever the patient needs. So when it comes to scientific inquiry, sometimes it's great to be able to split a little bit, but also understanding the benefits of lumping these diseases together, that there is shared features to them, but we can better understand them and approach them by finding these little endotypes within these bigger diseases. And then the last one that I've alluded to several times, which I could talk about for years and years and years, talk about burnout, is treatment access. So one horrific thing, and I say horrific, I'm being dramatic, but it really is horrific, is when someone gets on Medicare, there's a lot of limitations that those patients have in accessing some of our best medications and our safest medications. And the sad reality is that if you get on Medicare, you have less access to some of the newer, more effective treatments than you do if you're not insured. And this is so horrific because, again, aging is something to be honored. And if we are now treating people who've gotten to that goal, they've gotten to the age, they've paid their taxes, they're part of our Medicare population, and then we pull the rug out from under them, we are doing them an injustice. And that's one of the biggest reasons why I think burnout is such a high rate in dermatology, is because a lot of our older adult patients can't get access to the treatments that they need, and we end up having to fight insurance companies and fight the patients because they don't understand this new system. A lot of patients are still stuck in this world of wishing that you go to the doctor, they make a diagnosis, you send the prescription down to the local pharmacy, and you pick it up that day. And we all know, and if you don't know, you'll know soon, that that's not the case. Things wait a long time. There's a big numbers thrown around. There's tons of hands. If you're thinking back to that loop of despair where there's so many different people involved in sending a prescription, this is a major issue, particularly for for the Medicare population. So this is something we need to work at from multiple levels, from the national level, and really from a political level as well. This is a major issue. And then, of course, the last one, and this is the dream for all diseases, is to have more targeted options for older adults. And I would say maybe that's not the goal, maybe just inclusion of older adults in some of our target options that are being studied for other ages. We hope to start working with the FDA and regulators on that through some of the work in our ERG and through the outcomes research group that we're working on. But there's a really exciting future here. I don't mean to harp too much on the depressing stuff, because all of this as a future is exciting and wonderful. And if you want to get stimulated, there is so many areas that this aging and dermatology mix can stimulate you. So come join us. And with that, I'm all done preaching. So thank you to the University of Arizona and to UCSF, and then all the team that we've built, and my mentors, Tim Berger and Katrina Abuabara, who are aging researchers and people who I think have really led the charge to change how our field is looking at aging. And so thank you so much. That's my son who gave me that horrible cough that I had in the middle, and my wife, who's probably the most important person for all of this. So thank you all for having me. I'm so grateful for you guys giving me this forum, and I'm looking forward to any questions.
Thank you so much, Dr. Butler. That was a wonderful talk. And I think we can all relate to seeing the elderly, itchy patient in our clinics. So thank you for your pearls and your insights. I was, while you were talking, I mean, you didn't specifically talk about this, and some might find it banal, but while you were talking, I was thinking about the elderly patient with, increasing numbers of seborrheic keratoses that become super itchy, and they might be kyphotic and limited mobility. In fact, I had a patient last week whose, wife thought he was completely diseased and didn't want to apply his triamcinolone. What do you do with patients like that who are so limited by mobility, who can't even apply their own topical therapy? It's so frustrating. And I know seborrheic keratoses are just SKs, but
Yeah. I mean, it's really hard. And I mean, there's, I wish I had the answer for you, but I think that just having that conversation with the patient is like, I understand that your mobility limits your ability to do this. What are some effective ways we can approach this? What do you think? And asking the patient how they could approach it. And sometimes they'll shrug their shoulders and say, hey, look, this is all I have. I don't have anything. Or sometimes they'll say, yeah, I have a son or a daughter who could come once or twice a week to apply my triamcinolone on my back. There are little tiny sort of like common sense things that pop up in these conversations that I always find are brilliant. But sometimes that's even the impetus to say, yeah, you're someone who has to be on systemic therapy, not specifically for seborrheic keratoses, but sometimes that's also the impetus for me to just treat a seborrheic keratosis with a little liquid nitrogen and say, look, we're going to get it done here so that you don't have these provocative SKs all over your back. And even though I know you do well with triamcinolone on the back and we don't have to destroy these, you don't have that ability, so we're going to do it in a different way. But again, it's back to that conversation with the patient of, hey, this is the limitation I have with this. Let's try to work together to figure out a way to solve this.
And kind of relatedly on a note of itch, what labs do you normally check in your practice for primary pruritus where there's no rash?
So primary pruritus, I don't do anything particularly unique. if it's under 1 year, that's when I start to really, really worry. If someone's been itching for some generalized itch for under 1 year, I'll order a CBC, CMP, TSH. If it's an older adult, I'll also do a little bit of a sort of immune profiling. This is back to those overlying hoops. I'm not necessarily looking for the cause, but I'm looking for a suggestion of if they have an immunologic element to their itch. So I'll do an IgE. I'll also do SPEP and IFE and bullous pemphigoid antibodies. That's sort of like my immune profiling in older adults workup as well. And again, that's not exclusively looking for one cause of their itching, but it's more if they have an elevated IgE, I'm starting to think, oh, this may be someone who's more immune in their itch. And so this is someone who we may have to escalate beyond just triamcinolone to maybe phototherapy or another systemic option.
Okay, great. And we've got a question from the audience. They say, excellent presentation, Dr. Butler. What is the concordance or discordance that needs to be further elucidated in human organism aging versus cutaneous aging? For example, photoaging differences. How do we quantitate this?
That's such a good question, Dr. Piddleco. Thanks for that question. I wish I knew. This is where I need basic scientists and pathologists and sort of everybody coming together to start looking at these things. And I can tell you with almost 100% certainty, there's not many people looking into that. And I will add another question to your question, which is how those elements of photoaging then influence these sort of major players in diseases like the immune system, like the cutaneous nerves, like the barrier function, because each one of those are getting influenced by this sun damage, and then ultimately have a splayed response. Like it's not uncommon for people to see specific rashes in photo distributed areas because of that damage. So from a basic science standpoint, there's a lot to discover there. I wish I had a better answer for you.
Okay, thank you. And then I guess because we're kind of short on time, just do you have any advice for trainees that might be interested in this area, or can you speak about your career trajectory and the challenges you faced?
Oh my gosh. In 1 minute. Yeah, that's like the hardest thing I've ever done. I mean, my advice to any medical student, any trainee, anyone who's interested in this, whether you're a senior in your career, is find a population that like melts your heart, that makes you feel for them and their struggle, and find the holes in how we as a specialty are treating them. And it's hard to do that as a trainee, but you'll start to see them. You'll be like, wait, why did this person treat that in that way and this person treated in that way? Like what's the disconnect there? And once you relate it back to the patient struggle, then those holes become a little bit more apparent. And you're lucky to find that. The hardest thing in dermatology, in any career in medicine, is finding what you really love. And that often has to, come back to the patients. Sometimes it's basic science as well, but it really has to come back to the patient. So just find a group of patients that you're really interested in, and then keep a keen eye on them. And that will really, really help you as you explore this. Of course, if you're interested in aging specifically, just send me an email and I would love to connect with you.
Thank you so much. Thanks so much for your time, and thanks everyone for joining us. If you want to chat to Dr. Butler, email him or connect with him on Twitter. I think you shared your handle, but if you just want to repeat it once more.
Yeah, and I'll put my email is dcbutler at arizona.edu, and I can give it to the organizers as well. They have it. And then my Twitter handle is at Daniel Butler MD. So again, I thank you guys. Thanks for putting this on for the whole specialty, not just my talk, but these global talks are just wonderful, and they cover a lot of wonderful topics. And we're lucky to have you guys as people who highlight these wonderful researchers and creative people in our specialty. So thank you.
Thank you so much.